Listening to Dr. Radio on Sirius XM Channel 110. This is the Rehab Show. We're going to be talking about rehabilitation after the hospital, specifically in a nursing home or a subacute rehabilitation setting. Steve, welcome to the show. Good morning.
Good morning, Jonathan. How are you today?
I'm great. Thank you so much for joining us. Dr. Steve Gnatz, for our listeners, is Chief Rehab Officer at Integrated Rehab Consultants. This is a nationwide group of physiatrists practicing in subacute rehabilitation. This year, retired, congratulations, as professor in the Department of Orthopedic Surgery and Rehabilitation at Loyola University Medical School in Maywood, Illinois, and is a past president as well of the American Academy of Physical Medicine Rehabilitation. And Steve and I met in San Antonio at this year's assembly of AAPM&R, and we talked about subacute rehab. And Steve, it's my pleasure to have you on Dr. Radio to talk about subacute rehabilitation again. Firstly, how are you doing?
I'm doing fine, Jonathan. It's a pleasure to be here early in the morning with you.
Yes, I know it's early for you, for us. I do appreciate it, but we're going to make it stimulating and interesting and keep our listeners wide awake as well. So let's start from the top. Steve, when we talk about subacute rehab, what do we mean by that? Where does just describe for us the field of inpatient rehabilitation? Where does it fit into the continuum of care that somebody may be going through?
Sure. As you and I have discussed before, for the audience, inpatient rehabilitation, hopefully nobody in the audience will need it, but obviously people do need inpatient rehabilitation. They can't go home directly from the hospital, and so therefore they have to rehabilitate in an inpatient setting, a hospital setting. Probably most of us who grew up in rehabilitation medicine were familiar with rehabilitation hospitals and units of acute care hospitals that are rehabilitation units. That's where we all trained. That's where we all, kind of did most of our rehabilitation work over the years. For me, one of the things that happened in my career was about maybe 15 or going on 20 years ago now. I started to see my patients kind of drift off towards the skilled nursing facilities for their rehabilitation. And because I really didn't have much experience in that realm, I started a little migration myself to kind of follow my patients into the skilled nursing facility environment and see what kind of rehabilitation was going on out there. So it kind of, like I said, started an exploration on my part to see what skilled nursing facility rehab was. Over the years, it kind of became an idea that we needed to have more physical medicine rehab physiatrist participation in the skilled nursing facility rehab environment.
Right.
So that's how it kind of came about.
So when somebody's in the hospital, they've had an operation or they've had a medical condition and they're sick, they're weak, they're debilitated, as you said. People who go for inpatient rehabilitation, they can't go home at this stage. And the options that appear to be out there, two significant options. One is, as you described, the acute rehabilitation hospital, which may be a freestanding facility, or it may be a unit within the hospital, or going to a subacute rehabilitation center. Is that correct? Those are sort of the two major options at this time in terms of, where does somebody go who's not ready for home but is too weak or deconditioned or not functional, not safe, or medically there are issues. Where can they go in between the hospital and home?
Right, that's exactly right. There are those two main inpatient rehabilitation. There's one more, the long-term acute care hospital.
Right.
But for the most part, people either go to an acute inpatient rehab facility or they go to a skilled nursing facility, also called a SNF. The differences between the two levels of care are not as well defined as one might hope. Sometimes a lot of things that could be done in a skilled nursing facility are done in an inpatient. Things that could be done in an inpatient rehab facility are done in a skilled nursing facility. So there's some overlap between the two different facilities. But to make a long story short, people get inpatient rehabilitation in the two different levels of care.
Now, You're right. You were alluding to our training as rehabilitation doctors, as physiatrists. We see ourselves as the experts in managing the comprehensive care of individuals with functional limitations related to their medical or surgical illnesses, and in terms of coordinating a team and restoring people to their function. But in our training, we had little to no exposure to the subacute rehabilitation world. Our field had been pretty much exclusively dedicated to the acute inpatient rehabilitation side or outpatient sites. And so I had very little exposure to subacute rehabilitation. But things are changing these days in terms of where our patients are going. As you said, you wanted to follow your patients. Some of them went to acute rehab, some of them went to subacute, but you didn't want to lose them. So how have things changed, and how does it stand now in terms of the growth of the subacute rehabilitation sphere? And I guess my broader question is, how does the physiatrist or the treating team in the acute care setting decide, oh, this patient goes to acute rehab, this patient should go to subacute rehab?
Yeah, those are all great questions, and I guess the answer is that it's not always, unfortunately, it's not always as consistent as one might hope. I mean, you would hope that there would be defined characteristics that a patient that met these particular characteristics went to one level of care or the other. But unfortunately, because of a number of factors, including some regulations and other things that have limited the number of patients and the type of patients that can come into acute inpatient rehab center, what's happened in the last at least 15 or 20 years in the U.S. is that more and more patients have gone to skilled nursing facility environment and, have just, that's become kind of the default. As I've said before, more people in America get their rehabilitation in a subacute skilled nursing facility environment than in acute rehab today.
Yeah, so that's very interesting, and most physiatrists, most rehabilitation doctors who we consider to be the experts to manage patients in any kind of rehabilitation setting, they're not tuned into the subacute rehab sphere. So we're seeing this mismatch here, this gap in the field, that lots of patients are going to subacute rehabilitation centers, but yet physiatrists aren't trained, or perhaps aren't even looking for jobs in these areas, and yet we know that they're an ideal, an essential part of the treatment paradigm of patients in a subacute rehab center. You're listening to Dr. Radio on Sirius XM Channel 110. This is the Rehab Show. We're talking with Dr. Steve Gnatz, who is an expert in this field of subacute rehabilitation and physiatrist rehabilitation doctors working in subacute rehabilitation, and is the Chief Rehab Officer at Integrated Rehab Consultants, which is a nationwide group of physiatrists practicing in subacute rehab, so he has a tremendous amount of experience. Of course, the lines are open, 1-877 NYU Docs. That's 1-877-698-3627. Do you have a loved one who's in a subacute rehab center getting rehabilitation care? You have questions about that? Or perhaps you yourself or a loved one are in an acute hospital right now working on this decision. Where should you go for your rehabilitation care? And you have a question and you need some guidance from Dr. Gnatz, who's an expert in this field. 1-877 NYU Docs. That's 1-877-698-3627. I'll even say there may be some practitioners out there, physicians or nurses or therapists working in subacute, and you want to call in and share your story and talk about the work you do. Give us a call, 1-877-698-3627. So yes, Steve, there's lots of things that come into the decision about a patient going to subacute rehab. Let's talk more about this gap in terms of physiatrists, rehabilitation doctors, these experts in managing people with limitations from their medical issues. How can we change this sphere, this world, this environment? How can we make a difference and get physiatrists more engaged and involved in subacute rehabilitation centers?
That's a good question, John. So we are doing that. That's actually one of the reasons we founded the company, Integrated Rehab Consultants, was to provide physiatrists for skilled nursing facilities, and we've been fairly successful in doing that. We're in 23 states now, but we still have a long way to go. There is, I think, as one you alluded to, while we all grew up in acute inpatient rehab facilities, and there's a mandate to have a rehabilitation physician involved in your care if you're in an acute inpatient rehab position federally, a federal mandate, there is no mandate for there to be a physiatrist associated with your care if you're in skilled nursing facilities. So one of the things I think patients and families can obviously ask is, is there a rehabilitation physician who's going to be on my case if I go to a skilled nursing facility? And unfortunately, it kind of becomes the responsibility of the patient and family to understand that and to look for it, because, as I said, there is no mandate, not mandated from a federal level or something like that there's a physiatrist involved in your case.
Right. So what we would consider to be the gold standard, as in having a physiatrist really manage your rehabilitation care at a subacute rehabilitation center. There's many subacute rehab centers that do not have physiatrists. As you say, your companies work, in 23 states. There's still plenty of states without your company and without other companies and without physiatrists working in subacute rehab centers. But it's interesting because there is a sort of buyer beware kind of thought here that, there is a choice about what subacute rehab center an individual goes to. Here at NYU, where I work, we give individuals and families a choice of 5 different rehabilitation centers, subacute rehabilitation centers, and they can make a decision based on, what their preference is. Sometimes it's geography, sometimes it's a specialty unit, but one of the factors that we look for as well is there a physiatrist there? Is there a rehabilitation medicine doctor there? And that is really, really key. And what's the role, Steve, of the physiatrist, of the physician who's expert in physical medicine rehabilitation? What is their role in managing a patient at a subacute rehab center?
So, for your audience, I know you know this, Jonathan, but what we do as a physiatrist is we essentially help to manage the team, to direct the rehabilitation care, to look for obstacles, barriers to discharge that might be present, and try to problem solve with patients and families. I kind of see myself as the captain of the ship, so to speak. I'm not really physically doing a hands-on rehabilitation with any patient any day, but I'm aware of what all the therapists can do. I speak their language. I can talk with them about issues or problems that they're having. I help direct the rehabilitation all the way through from initial state to getting the person home and obtaining equipment, those types of things, dealing with medication issues. So the rehabilitation physician has a wide-ranging role in this environment, but it's certainly a very important role.
Yeah, I agree with you. It is very wide-ranging, but it is also very important, and there are so many elements to rehabilitative care that require that expert input, and many other practitioners don't have the background, don't have the training, don't understand the nuances, perhaps sometimes even the basics of rehabilitative care, and as you said, different kinds of equipment and home care needs and safety issues and the complexities of not just being able to stand and being able to walk, but communication skills and swallowing skills, the impact of vision deficits on function. So rehabilitation doctors spend their training and their career in these fields, and there's really not another specialty trained like us in managing these patients. Again, I agree. I think if I am to choose for myself or a loved one a subacute rehab center, if there was not a physiatrist there engaged, I would not send my loved one there. We have an email, Steve, I want to read off to you, get your thoughts on this. Comes from Marcy in Georgia. It says, my 85-year-old mom has been hospitalized a few times in the last year for complications related to heart failure. Each time, she is very resistant to going to step-down rehab facility afterwards, even though the doctors think this would be beneficial. All she wants to do is go home. But when we wind up back in the hospital, how can we talk to her about this and convince her that rehab would be helpful? What exactly would a rehab center do for someone like her? She is frail and prone to pneumonia. So this is a very interesting question, because I think it has there's subplots here. Number one is, are there diagnoses and conditions that are not appropriate for a subacute rehab center? That's question number one. Question number two is the impact of a subacute rehab in terms of not just getting someone back on their feet, but can it make a difference in terms of the medical course and reducing readmissions?
Absolutely. So great question. A couple of great questions. Let me just start by saying that congestive heart failure, is a common problem. It's also one that you will not see in your acute inpatient rehab center really too much anymore because unless it's a contributing or comorbidity, the problem is that those patients have gone to the skilled nursing facility, and if they're not in a properly designed cardiac rehab program, they probably really won't get that much better in a skilled nursing facility. I mean, you and I have had this conversation where,
yes,
historically, patients have just been kind of warehoused in skilled nursing facilities. But what we're really trying to do is change that paradigm so that there are active rehabilitation programs that a person with, say, congestive heart failure is going to get in a skilled nursing facility, and they can make a tremendous amount of difference. That increase in the intensity of the rehabilitation, their ability to exercise and to become more conditioned can keep them from being readmitted to the hospital, keep them from falling, keep them from having all kinds of bad outcomes from their congestive heart failure. And so, yes, I would say that it's good to be trying to convince your mother to go into that program like that, particularly if it's well run, well organized, because it actually will prevent further problems down the line.
Yeah, I would agree with everything you said, Steve. Marcy, hopefully you're still listening. There is a choice about what subacute rehabilitation center you go to. You can visit the subacute rehab centers in your locality to make sure they meet your needs, both from appearance, both from cleanliness, both from staff, your understanding of how the staff works. But I think also if your mother has heart failure, making sure that there's a strong medical model in terms of medical management. And also, as Steve has been saying, Dr. Gnatz has been saying, having a rehabilitation physician on board as well is very, very important. And you're right as well that if your mother does go to a rehabilitation setting, a subacute rehab center, and gets the right care, then the chances of a readmission back into the hospital go down. The data supports that as well. There is a very positive impact of the correct rehabilitation program on one's medical stability and risk of readmission. So, Marcy, you bring up great points there. Check out your local subacute centers. The conversation, yes, it takes convincing. It takes perhaps say, listen, you go to a subacute rehab center, it's an extra 10 days or 20 days in the hospital, but if it can limit your readmission possibility, that's tremendous. Steve, we have a caller. We're going to Georgia. Tom, welcome to the show. Good morning.
Good morning.
Hi, Tom.
Dr. Jonathon. I have a couple questions. I've had two in-laws that went through extended illnesses in several types of facilities, and I had two main questions. Number one, I want to ask you to define your terms a little bit more because I'm confused, and I think I'm a reasonably intelligent healthcare provider. What is a physiatrist? What is their training? And I'm confused about that. In all of the time my in-laws were through the end-of-care transition, this term never got discussed. It was never provided as a resource. I am totally confused about what a physiatrist is.
Well, let's answer that one for you, Tom. Steve, you want to take that? What is a physiatrist? Sure. Dr. Gnatz is a past president of the American Academy of Physical Medicine and Rehabilitation, so he knows this one.
Yes, sure. I'll take that one. And in fact, it's a great question.
Yes.
There are about 10,000 physiatrists in the United States today, but we're probably a little known specialty. The specialty is defined as the medical specialty that deals with all types of disabling or potentially disabling conditions. It's certified by the American Board of Medical Specialties. We've been around since a little bit after World War II. I think 1949 the board was established. So we are physicians of function. We don't have an organ system, and that's maybe one of the issues. We can't say we're a heart doctor or a kidney doctor. We're really doctors of function. We're doctors that work with your team of rehabilitation professionals, get training in the whole rehab process, and that's really our specialty, is getting people through the rehabilitation process. So there is no other really unique specialty, and sometimes, I guess unknown or unrecognized, but clearly a specialty that you need to have on your team if you're going through rehabilitation.
Right. And our training, we go through a year of internship and then 3 years of residency. Many of our colleagues go on to do specialization fellowship work, and they may train in pediatrics, or they may train in spinal cord or brain injury or cancer rehabilitation or musculoskeletal spine and sports. My fellowship happened to be in cardiac and pulmonary rehabilitation. So we become subspecialized, Tom, in particular areas. Tom, I apologize, but we're rapidly running out of time. I don't have time to take your second question. And Steve, we really literally have just a minute left until we have to go to the break. So just in summing up, what's your recommendation to people when they're looking at subacute rehabilitation centers and recognizing the need for their loved one to go there? What should they be looking for?
So my main suggestion, I think you touched on it before, is that they find out if the program, the skilled nursing facility has a physiatrist, and the competencies of that particular skilled nursing facility, how they match up with their loved one's needs.
And for people to recognize that there are choices out there, and they can go pay visits. We recommend our patients leaving our hospital to go pay visits to the subacute rehab centers, see where they are, and then there's scoring systems as well. I can't remember what's the name. There's a place where you can look at the rankings or ratings and compliance of subacute centers.
Yes, the star rating. So
star rating,
ratings,
yes.
Do help. I think the Centers for Medicare and Medicaid Services are taking steps to make sure that the facilities are more comparable. It's not a perfect system, but right. I think that people can look at it.
Give some insight. Steve Gnatz, thank you so much for being with us. I look forward to talking with you again in the near future about subacute rehab. Have a great day, Steve.
My pleasure, Jonathan. Thank you.
Thank you. Take care.